All right, good afternoon and welcome to the Firefighter Cancer Initiative monthly seminar series. Feel free to adjust your audio settings and acquaint yourself with the Zoom environment, and we will start in a few minutes. We'll give like a little, give another minute over time for folks to trickle in, who I see our list is growing, and then we will introduce our speaker and get the seminar going. So welcome, welcome. All right, so welcome. If you're joining us, we're here for the Firefighter Cancer Initiative seminar series. We'll give just another minute for attendees to log in, adjust audio, and then bless you, Tosh, bless you, to get started. Oh my goodness, okay.
I'll stay muted, so I'm like sneezing.
All right, we'll go ahead and get started. So let me just say good morning or good afternoon, wherever you're joining us from around the world. It is Tuesday, April 22nd, and we are hosting the National Firefighter Cancer Initiative's monthly scientific seminar series. My name is Alberto Caban, and I'm joined by my partner in crime, Dr. Natasha Sali, to introduce our presenter today. It is with great pleasure that I get to introduce our colleague and Sylvester Comprehensive Cancer Center member, Dr. Justin Taylor, who's a physician scientist and works in the area of hematologic malignancies, cancer. And his lab is amazing because it focuses a lot on our ability to understand how recurrent mutations really impact different types of cancers and how we can align therapies and treatments and personalized approaches to this type of care. So we're going to be talking about blood cancers, and this is really important because oftentimes our firefighters, that talk about the different types of cancers that come up within the fire service. Some that are less talked about are some of our liquid cancers, like lymphoma and leukemia. As you all remember, back in 2022, the International Agency for Research on Cancer classified the act of firefighting as a group 1 carcinogen, the highest category that you can give. And that was primarily driven by mesothelioma and bladder cancer. But in that evaluation, one type of blood cancer, non-Hodgkin's lymphoma, was elevated in risk for our firefighters. So thanks to scientists and physicians like Dr. Taylor, we're getting more insight into more about how these blood cancers arise and how the occupation of firefighting impacts that work. So without further ado, please join me in giving a warm welcome to Dr. Justin Taylor, who's going to be talking to us about the emerging importance and understanding of disease risk in firefighters. So Dr. Taylor, the floor is yours.
Thank you, Alberto and Natasha, and thanks everybody for joining me and the invitation to speak here. I'm going to share my screen now and we'll get started. Okay, I hope you're all seeing the correct presentation. So I'm getting the thumbs up. Yeah, going to be using some big words here, but I'll just, I'll put lots of definitions out there. And clonal hematopoiesis is the topic of this seminar. I'll define what that is, and then from the future, just for ease of saying it, because it is a large word, a mouthful, we also refer to this as CH, so just the acronym CH for clonal hematopoiesis. And I'll be discussing, the kind of emerging understanding of this, what the importance is to not just the firefighters, but our general understanding of how this clonal hematopoiesis contributes to blood cancers, the risk for blood cancers, and then specifically hone in on the risk in firefighters. So as Alberto said, I'm a physician here at the Sylvester Comprehensive Cancer Center. My clinical focus is on diseases of blood cancers, leukemia specifically, and other related blood cancers. And I also have a research laboratory where I'm an associate professor in the translational and clinical oncology program at Sylvester and the University of Miami Miller School of Medicine. So again, the overview of the talk today, and I'm going to leave lots of time for questions. I'll go slowly, and I don't have too many slides. So yeah, please put them in the Q&A or chat, and we'll get to them at the end. But I'm going to review what is clonal hematopoiesis. Again, we have a evolving understanding of this. It's one of the I would say the fastest growing fields, where every day, almost every day, every week at least, there's a new publication and a new finding, I guess, that increases our understanding. So it's still changing. I wouldn't say that we know everything about it. It was first described in 2015. So, 10 years now, we have a lot better understanding. Yet we still don't know everything about it, especially when it comes to all the risks, such as firefighters, which will be the focus today. So after we review that, we're going to, again, talk about our results that we have. Again, we're still in the process of this study that we're doing with the Firefighter Cancer Initiative. And I'll tell you about our results in our cohort that we've sequenced for this clonal hematopoiesis. And then I'll discuss, but hopefully we'll chat about the future directions and potential implications of our findings. So without further ado, what is clonal hematopoiesis? To put it simply, and again, I'll just refer to it as CH for ease of talking about it. This happens when a cell called your hematopoietic stem cell, these are the type of the type of cells that can differentiate or turn into different types of blood cells. So all your blood comes from the bone marrow, and these hematopoietic stem cells live in the bone marrow, or the soft part of the bones. And again, they lead to the development of all your different types of blood cells. However, CH occurs whenever there's a mutation in these hematopoietic stem cells, and they start making cells with that same genetic mutation or genetic alteration. So as a consequence, the blood cells that are generated from that hematopoietic stem cell that developed a mutation then have a different pattern, genetic pattern, than the rest of your blood cells. So we're able to detect this if we take a blood sample, perform sequencing for DNA, and we see that there is this different genetic pattern, and we call that CH. There are actually different definitions that have been used. Again, we're evolving our understanding of this, but it's now gotten to the point where we have a disease diagnosis, so an ICD-10 code for a clonal hematopoiesis, meaning we can actually call it a diagnosis. And there's a definition of that, which is the genetic alteration needs to be above 2% of the blood. Today, we're going to talk about how we're doing research and detecting clonal hematopoiesis even lower than 2%, but for the clinical definition, the cutoff is 2% or higher. And it's really not associated with any signs or symptoms, so there's no kind of warning. People probably don't know they have it, and only it's detected after there's genetic testing done, or this DNA testing done, which we're not currently doing for the, we're not currently screening for this. So it would have to be done for some other reason. For example, you're diagnosed with a common cancer, such as prostate cancer, breast cancer, lung cancer, colon cancer, and the oncologist there does a genetic sequencing panel. They're trying to, of course, they're not looking for this, but they're trying to sequence the genetics of your tumor. And since there is some blood, or maybe they use a blood sample as part of the sequencing, or even in the tissue, there's blood there. and they end up detecting this mutation, which is commonly seen in clonal hematopoiesis. That's how somebody might have this detected in the first place. But of course, we know about this through research, and as I mentioned, this was discovered in 2015 when people were doing sequencing of large cohorts of healthy individuals, or they didn't have blood cancer at least, and they discovered these mutations. So again, each person, depending on your age and other factors, you might have between, shown here in this drawing, 50,000 to 200,000 hematopoietic stem cells. And then just due to the way that the way that we think these mutations happen is due to the errors that can occur through replication. You would every person just through normal replication would be expected to have about one protein coding mutation every 10 years per hematopoietic stem cell. And so most of the time, these mutations are inconsequential, meaning they occur in a part of the DNA that has no effect on the outgrowth of these hematopoietic stem cells. Therefore, they don't turn into CH. So no consequence, nothing happens. That's what's most common. However, of course, as you age, again, every 10 years, you're getting one of these mutations that might have an effect. And so, of course, as you get older, then about 20% we think of elderly individuals, let's say over the age of 75, would develop a mutation that occurs in a gene that matters or causes this clonal hematopoiesis. And then again, the people who discovered this and went on to characterize it further related that having clonal hematopoiesis can put you at risk for blood cancer, as well as other consequences, which I'll get to in a second. So this is from their initial publication, actually, 2014. 2015 is about when these publications came out, where they described these mutations, and this is not an exclusive list, but these are the most commonly mutated genes that are seen in clonal hematopoiesis. And you don't have to memorize these, but I want you to kind of take a look at them, and we'll come back to it later and see how this may be different than what we see in the firefighters. So these genes, again, the names may not ring too many bells, but they're DNMT3A, TET2, and ASXL1. These are the most common, and this has been replicated in many other studies since this first publication, that these are the most commonly mutated genes seen in the general population. Then you have some other ones. Again, we won't go through all of them, but after these top three, maybe top 4 or 5, they become less frequent as you go down the list. And then you can see on the right lower plot here, this is using a cutoff of 2%, not of the frequency, but of each individual patient having a 2% clonal hematopoiesis. So again, with this cutoff level, younger people do not have clonal hematopoiesis at that cutoff level. Once you get to around 40 to 50, you start to see it uptick. And then really, again, over 70 is when you see that 10% or higher. Of course, even getting into very elderly people, it becomes even higher frequency of that population of individuals at that age having clonal hematopoiesis, using that cutoff of 2%. And then again, from this first studies, they showed that in this population, and it's been replicated again in other populations, having clonal hematopoiesis is associated with lower survival or increased mortality. So you're more likely to die. And looking at the causes of death, leukemia, which is the blood cancer we're going to be talking about, but there was also association with cardiovascular disease, solid tumors, and other diseases that are non-blood cancers. So the actual risk of hematologic cancer is estimated to be about 1% per year in an individual that has clonal hematopoiesis, over 2%. And so this is the upper right compared to having no clonal hematopoiesis. The risk of blood cancer is much less, specifically acute myeloid leukemia. But actually the higher risk, 40% increased risk in cardiovascular disease, which is heart attacks, blood clots, and heart failure. So again, since that initial publication, a lot of studies have focused on what is the risk for developing CH. We already mentioned age, that's the biggest risk. Another study, which I'll go over, linked smoking to CH. And then many studies look at what's called the germline predisposition or your hereditary risk for developing CH. Obesity has also been recently linked to CH. Sleep fragmentation. Yeah, each of these were kind of individual studies. As I mentioned, these are coming out all the time. There is this common link to inflammation. So chronic inflammatory conditions such as ulcerative colitis or rheumatoid arthritis. These are, these are not cancers, but they cause increased inflammation in the body, and that's been associated with CH. Likewise, infections, you have a reaction to the infections, especially chronic infections, HIV. There's more inflammation, there's more CH. And then, important to all of us who treat cancer, any type of cancer, is the cancer treatment, such as radiation or chemotherapy, and certain classes of drugs can have actually been linked to developing CH, and even worse, that CH becoming a leukemia due to the cancer treatment. So you treat the one cancer, but you end up with a different cancer, namely leukemia, blood cancer, due to the radiation or chemotherapy. That has actually been known about for many decades, but more recently it's been shown that a lot of it is due to clonal hematopoiesis, that the chemotherapy is not actually inducing the leukemia per se. It's more that the chemotherapy is allowing for the outgrowth of this clonal hematopoiesis, which was present before the start. So many studies are now looking at patients undergoing cancer treatment therapy and how they might mitigate the risk of therapy-related leukemia due to clonal hematopoiesis. And then there are many other, as I mentioned, other studies coming out all the time that show an association with developing clonal hematopoiesis. There was actually one in astronauts who go to space. They of course develop, they get more radiation out in outer space and had more clonal hematopoiesis. So again, kind of what's the weight of each of these? As I mentioned, the biggest risk factor, just because as of now, we don't have a way to halt aging. So each year, the odds ratio or the added risk is 1.08. So if it was 1, there would be no effect, or if it was less than 1, it would be protective. But so this is just slightly higher than 1. So there's a slight increased risk of CH every year that you age. And then you compare that to smoking. Here they looked at heavy smokers of 10 cigarettes per day. So of course, less than that would be less risk, but I think any smoking would be associated with risk. There, the odds ratio, again, not super high, but higher even than each year of aging at 1.17. And then what's shown in this plot here is the variants, the hereditary variants that have been associated with risk of clonal hematopoiesis. So again, these are mutations, or these are variants that you're born with. They vary throughout the population. They're called single nucleotide polymorphisms. So they're not what we're talking about. These are not CH mutations. These are in your again, hereditary DNA, but they've been found here in this study to predispose to developing CH. So again, I won't go through all of these, but many of these are in the same genes that ultimately develop into CH. So we're, as I mentioned, we're still figuring out how this link happens. And of course, not everybody with these hereditary mutations develop CH. So what is the, how do your genetics and the environment interact to ultimately lead to CH? Okay, what about firefighters? The thing we came to talk about today. There's actually some data, again, in 2022, so not too long ago, that looked at the risk for CH in firefighters. And in this case, they were looking at the firefighters in New York that responded to the World Trade Center. And they showed here the controls that they used were actually firefighters that were not World Trade Center first responders. So these were about 255 non-World Trade Center exposed firefighters and 481 World Trade Center exposed firefighters. And so in this study, they showed that the World Trade Center exposed firefighters had a higher risk of CH, and you can see in the red line here. It was also age dependent. So again, this could be something that they were at a certain age when they were exposed to the World Trade Center, and then as they aged, the clonal hematopoiesis risk increased. Again, when you look at the 70 to 79-year-old individuals, it was 31%. And the general population, that would be around, again, 15 or 20%. And here in the firefighters that were used as a control here, they had 15% risk. But I would say, in this study, they did not use any healthy controls, or they did not have any comparison for the firefighters that were non-World Trade Center exposed to see, is this actually higher than the general population? I think they presumed that it was not higher than the general population. And when you look at the mutation seen, again, DNMT3A, TET2, they actually did not sequence the ASXL1 gene, but that would likely have been the third most common. Those are the three most common. But they did see after that some differences in the types of mutations that occur with in order of the frequency of mutations. And then again, I'll kind of go over this again in our study, but it may be that there are different types of mutations seen in some firefighters, not all firefighters. And as Alberto described in the beginning, the IARC in 2022 changed occupational exposure as a firefighter to carcinogen group 1, which is the highest level. Previous to that, it had been categorized as possibly carcinogenic, or group 2B. That's for certain types of cancers only. Again, they classify either sufficient, limited, inadequate, or strong evidence of different things. And so there is sufficient evidence, or the highest level, for cancers of the lungs, mesothelioma, and bladder cancer, and then limited evidence for colon, prostate, testicular melanoma, and, as Alberto was saying, non-Hodgkin's lymphoma, which is a different type of blood cancer. They have not yet had adequate evidence for leukemias, the blood cancers that we're going to talk about specifically. And again, CH, or clonal hematopoiesis, was not really looked at in this publication. And again, these are related to the possible exposures to the polycyclic aromatic hydrocarbons, building materials such as asbestos, especially mesothelioma, PFASs, and other chemicals, the flame retardants, possible just diesel in the vehicles. And then if you recall, I mentioned that shift work was a risk for CH. So again, they linked shift work to this possible carcinogenicity. And then there is a possibility for radiation and UV exposure, although UV is typically linked to melanoma, not leukemia, but any other radiation exposure would be, as I mentioned, potentially causing the clonal hematopoiesis to develop into leukemia. Again, wasn't studied in this publication, but that led to us, thinking about this idea and working with Alberto, also other people here at Sylvester in our sequencing core at the Cancer Center, Sean Williams, Jake McCauley, Patrice Whitehead, and Dr. Aaron Kobitz, through the funding from the state of Florida. And our hypothesis, or what we wanted to test in this study, was whether CH in firefighters is associated with cancer risk, again, specifically blood cancers. So we started with a population of one of the FCI cohorts that was collected here at Sylvester and in the University of Miami with the help of a lot of people on this call. And over 800 blood samples were stored from this cohort. We randomly selected 500 of those samples from this FCI annual cancer survey cohort to extract DNA. We have a machine here that can extract DNA from 500 blood samples at the same time. And so we took, again, this random 500 out of the over 800 samples that are stored, extracted the DNA, and we've been each year that there's more funding, we sequence more and more of these samples. So out of those 500, 200 samples were moved forward for QC, which is quality control analysis. And then the way that the sequencing is done is on these plates, which have 96, the possibility to sequence 96 at a time. So we've done 2 of those plates. Again, this is a relatively expensive and painstaking process. So it's over a couple of years. We've gotten now to 192 samples that have moved forward to this sequencing, which I'll talk about the sequencing technique in a little bit. And I'm going to show you the first 143 samples that we've analyzed. We've actually sequenced the other 49 as well. And we had 3 healthy control samples that we sequenced, but we haven't yet analyzed those in with this bunch. I'll show you our first 143, which includes some new data that haven't been presented before. And then we're working with the team here to, these people are being followed to see, did they ever develop cancer? So what is the cancer risk associated with having clonal hematopoiesis, and then what are the outcomes of cancer in those individuals? And we performed this type of sequencing called duplex error-corrected sequencing. I won't spend too much time on this. It's pretty technical, but the typical type of sequence we do has a possibility of having errors down to around 1%. So just shown here on the left, you can see these mutations are not real. These are kind of background noise, if you will. And so typically that's why we use the 1% cutoff. And in the decision to use 2% cutoff for clonal hematopoiesis was even to be more cautious, just to make sure that what's being diagnosed as clonal hematopoiesis is not kind of in this background noise. They use a 2% cutoff. But you can actually go down to 1%. Anything above 1% would be considered a quote unquote real mutation. And it just means that less than 1%, we can't be confident because there's a lot of noise. Duplex sequencing, again, I won't go all over the details, but it has a much higher sensitivity. And in this case, even down to 0.01%, you can confidently detect this mutation because there's not a lot of background noise or zero background noise. So this one mutation could be confidently, even though it's very, very low, here you wouldn't see it in all this noise. Here we can detect it as an example. And this is how it's done. It basically uses these duplex tags, and you're able to detect what's a true mutation from these errors that are generated through the process of sequencing. If there's an error, it would just be in one of these pairs and not both pairs. If it's seen in both pairs, like this A and the T, then you're confident that you're eliminating all the error. And so this, we're not the ones to invent this sensitive technique. It was actually used by a group in 2017, looking at the nurses' health study. Again, this is a group of nurses in Massachusetts, and the average age of that population was 56. So again, if you think back to using the 2% cutoff, in the 50 to 60-year-old range, clonal hematopoiesis was only detected in about 1% of the population. So they had 20 individuals in this study, and again, using that 2% cutoff, out of the 20 individuals, at 1%, they would have had very few detectable cases of CH. However, when they used this sensitive technique, they actually detected in 19 out of the 20, so not everybody. There was one individual where there was no clonal hematopoiesis. And here in some of the individuals, like this number 7, they had up to 16 mutations or clonal variants detected. So again, this sensitive technique allows you in the younger individuals to detect clonal hematopoiesis below that clinical threshold. So looking at the roughly 800 firefighters from our cohort, this is the age distribution. So some in the 18 to 20-year-old, a lot in the 20s to 35s, most of them in 35 to 40, and some 45 to 50, but not too many over 55. So again, since we had this younger population, if we use the regular sequencing technology, we would expect to find 0 to 1% of the population having clonal hematopoiesis by that definition. So we wanted to use this more sensitive technique to be able to detect even subclinical threshold clonal hematopoiesis. So what we were not expecting to find out of the first 96 samples that we sequenced is that we actually detected more than one clonal mutation in all 96 samples that we sequenced. So I think the lowest we had in this initial was 3 mutations or 4 mutations in this individual here. And we also had some that had very high number of mutations, similar to that nurse's study, but also some individuals that had 50 plus mutations. And these were actually filtered. We were not counting, even though you were able to detect a lot of mutations with this sensitive technology, we were not even counting all of them. We were trying to be conservative and filtering out to just these that are expected to have a functional consequence on the gene. Just to make like as a sanity check to see that these mutations that we're seeing are likely actual CH, we looked at the age, and you can see here with the younger individuals on the left, like starting with the 20-year-olds and all the way up to, we had someone that was almost 60, and then some did not report their age, but of those that reported the age, you could see there was a trend towards having more clonal hematopoiesis, like the ones that had the 50 mutations, or in the 60 to 70 year, 50 to 60-year-old age range. So that does suggest that most of these are clonal hematopoiesis, since clonal hematopoiesis is predominantly age-related. So now I mentioned we were going to show you the unpublished data, or the never before presented data. We now have 143 samples, and again, we've sequenced about 50 more that we're going to add to this. And we continue to see all the individuals that we sequence have had clonal hematopoiesis. So out of the 143, all 143 have had clonal hematopoiesis, again, with some having, now we see a few more that have kind of low number of mutations, less than 5, but everybody having more than 1. And again, some that have here very high number of mutations. When we look at the type of mutations that are seen, and again, here's where we compare it to kind of what's been published. We didn't here sequence any non-firefighters. This is all firefighter data that I'm showing you right now. But when we compare it to what's published out there from other clonal hematopoiesis studies, we see some difference in the frequency of the types of mutations. So we actually still continue to see that the DNMT3A, TET2, and ASXL1 are the most common. That's the ones that I mentioned were most common in the general population, most common in that study from the World Trade Center firefighters that used non-World Trade Center firefighters as controls, and the most common in our study. Again, suggesting that these are likely clonal hematopoiesis mutations that we're detecting. However, if you look, so they're ranked on the left is the most frequent down to the least frequent on the right. And so here, towards the left side, we see these genes, TP53, CHEK2, PPM1D, and RAD21. These are all DNA damage response gene mutations, meaning that the gene that this mutation is occurring in is known to be responsive to any DNA damage through, say, radiation, chemotherapy, any sort of insult to the DNA would cause a response from this gene. And if the mutation in this gene causes the protein that's a consequence of the gene, so to be non-functional. So these are, again, most of the mutations that we saw were either a gain of the stop or a frame shift variant or a missense, but they're likely damaging the function of the protein. So if that protein or gene is not functional, then the DNA damage is going to be allowed to remain in the cell, and that could then predispose to cancer. So these types of mutations, these types of clonal hematopoiesis mutations are more dangerous, if you will, for the people who are exposed to DNA damaging toxins such as chemotherapy, radiation, others. Again, we didn't sequence any non-firefighters, so we don't know for how frequent these might be in a kind of general population, but just from what's reported, we see higher numbers or more frequent in our population than in other publications. Then you can look at the, not just the gene that the mutation happens in, but what does the mutation do to the DNA? How does it change the sequence of the DNA? So the DNA is made up of just 4 nucleotides, and we call them T, C, G, or A to denote those different nucleotides. And it has been, it's been shown before, such as in the study that I mentioned on the earlier of the Nurses' Health, that having a C to T mutation, so it's the original sequence of the DNA is a C, and then it becomes a T. That type of mutation is associated with the aging process. And so that was the most common occurring mutation in the Nurses' Health study, as well as all these other clonal hematopoiesis studies, and was also the most common mutation occurring in our population. And if you just look at the pattern of these different base substitutions, our data matches the data from the Nurses' Health, not exactly, but in the same type of pattern. Although I would say, looking at the number of mutations, we have a lot more mutations than we're seeing in the Nurses' Health study. And these were similar error-corrected type sequencing, very sensitive sequencing. Although, again, we did not reanalyze their data, or it can't be a direct comparison. This is just with what's available to us now to compare it to. Okay, and then separately from the detecting the clonal hematopoiesis, that was kind of one part of the sequencing panel that we ran. This sequencing panel had a unbiased mutagenesis analysis. So again, we focused our sequencing efforts on certain genes. We didn't sequence the whole genome. So we might have been biased in the areas that we chose to study. In this separate mutagenesis analysis, it's a unbiased, it's not a very large, it's not the whole genome, but throughout the genome, there's a separate 50 kilobase regions that are selected to be unbiased. So these are not based on any gene in the area, they're just scattered throughout the genome. And we still see these mutations happening, the C to T. So again, as the aging process occurs, these mutations are happening in the blood. Most of these are inconsequential. They're not occurring in any coding region. It just, over time, when they do happen in that gene, say P53 or DNMT3A, then that is expanded in the hematopoietic stem cell pool, and that becomes clonal hematopoiesis, or in this case, kind of precursor to the clinical clonal hematopoiesis. We also, though, besides the C to T, the aging, we did see in this kind of unbiased genomic region some of the C to A type of mutation, which could be caused by other exposures. We're still looking into that. So to conclude on clonal hematopoiesis, it's a new sort of in the last 10 years kind of recognized phenomenon, and only in the last 2 years or so an actual clinical diagnosis, but it can lead to blood cancers and other risks of higher mortality. However, this is rare. So again, I don't mean to, I'm showing you here that we're detecting it in all the firefighters that we sequence, but we're at a very, very sensitive level. So this is not to the level of a clinical condition. In fact, fewer than 1 out of every 100 people with CH get a blood cancer. So also having CH does not mean that you're destined to get a blood cancer. But there is this higher risk of cardiovascular problems, including heart attacks. So much so that it's about the same risk as having diabetes, predisposing you to cardiovascular disease. And then again, this study is still underway, so we don't yet know for sure, but firefighters may be at a heightened risk of CH, although we need to kind of do the same level of sequencing or equivalent sequencing in non-firefighters to really be sure that this is indeed a heightened risk. The next steps, again, I told you that so far we've sequenced almost 200, and we have now included 3 non-firefighter controls, but we would like to include more controls. The 3 that we did are more of a technical control, but as I mentioned, to compare it to the general population or maybe another population of individuals that could be matched for the same kind of age and every exposure except for firefighting, say, to really define the risk. We're also going to look at the obesity, smoking, the other risk factors to see if those could be potentially causing the increased CH burden. And then if anybody, these are one time point, so one snapshot. It's been shown in other studies. Very few studies have longitudinal samples where they follow people and sequence them again an additional time point. But in those that have done that, they've shown that in some individuals, the clonal hematopoiesis can actually revert or disappear. Most of the time it increases each year, but doesn't have to. And in some people it stays exactly steady. And then, yeah, this is again more technical, but this company that made our error-corrected sequencing is no longer producing that. So there's some other options for doing that versus, we could just use the kind of less sensitive technique, but still detecting clonal hematopoiesis at a 1% cutoff to continue the rest of the sequencing. And I'll just briefly go through this because I want to save time for questions, but the potential implications, again, we can't conclude that firefighters are at higher risk. I think that one study did nicely show the World Trade Center firefighters for sure were at higher risk of CH. And, you know, in my view, there could be certain firefighters, if they get high enough exposure, could be at higher risk of CH. It could have implications for risk of developing blood cancers. Right now, the epidemiologic data are just meaning counting the people who develop blood cancer called acute myeloid leukemia has not linked that with sufficient evidence to firefighting, as I mentioned, but I do think that needs further study. And, you know, it's possible that even though we're detecting a lot of the CH, it's kind of a lower level and maybe a lower risk than the general population, although I would say we have these DNA damage response genes that are kind of frequently mutated in the cohort that we studied. So that would argue against that. Even so, you know, if you have clonal hematopoiesis at the beginning of treatment for cancer, a study done here at Sylvester that I was a part of, along with led by Dr. Ben Diamond and Dr. Ola Langren, they looked at people receiving chemotherapy for multiple myeloma and other cancers like ovarian cancer. And they showed that if they had a mutation, a clonal hematopoiesis mutation, it is specifically TP53, that DNA damaging response gene mutation, prior to the start of the treatment for the cancer, they were more likely to get therapy-related myeloid neoplasm, and they were actually able to show through a pretty elegant whole genome sequencing study that it was that clonal hematopoiesis clone that grew over time through the treatment and became leukemia. So it's again, not that the chemotherapy caused a new leukemia, it's selected for the clonal hematopoiesis. So I would say if not just firefighters, but anybody having clonal hematopoiesis and then undergoing cancer treatment could be at a higher risk of a therapy-related myeloid neoplasm. So it does have some implications, even if you're diagnosed with another cancer that's not a acute myeloid leukemia. And then say if you are diagnosed with acute myeloid leukemia, there's some implications for insurance coverage, or coverage because of the exposure of being a firefighter, since AML is not yet linked to firefighting. But if clonal hematopoiesis risk is really higher, and we know that clonal hematopoiesis predisposes to AML, it could potentially have some implications there for insurance coverage. And these are just some of the initiatives going on at Sylvester Cancer Center. We have a clinic for clonal hematopoiesis. Again, we're not recommending people go and get tested, but if you're, for some other reason, you have sequencing and you see one of these mutations, there's a clinic where you can go and be seen. There's now a new risk categorization where they can look at a lot of features, including the types of mutations, the level of the mutation, whether it's 2% or higher or lower, clinical factors, blood counts, to kind of more accurately define the risk of a blood cancer. And then we know that there's this high risk of cardiovascular disease, so they work with cardiologists to do kind of preventative measures. Nothing is approved for the treatment of clonal hematopoiesis. There's some studies going on in our labs here at Sylvester looking at kind of high doses of vitamin C to try to prevent clonal hematopoiesis. Very promising studies. And actually nationally and internationally, there are studies, again, nothing's approved, but they're testing these for individuals that have this higher risk clonal hematopoiesis. Because again, it's not defined whether everybody with clonal hematopoiesis should get treatment, since the majority of them will not develop leukemia. However, if you have a very high risk possibly you would need a treatment. So it's being tested in clinical trials. They're looking at different metabolic inhibitors, anti-inflammatories like canakinumab. It's antibody for IL-1 beta, which is an inflammatory marker. Actually, they're testing vitamin C in patients now. And then there was a recent study that we were just talking about. It was published last week. Again, pre-clinically or not in patients, but in animal models, showing that metformin, a kind of diabetes drug, was associated with lower risk of a specific type of CH related to one certain mutation. So again, that could be studied in the future. It's not going on right now. They have looked at actually kind of retrospectively looking at people that were in randomized studies of aspirin, and they did not see any difference with people with clonal hematopoiesis. So we're not recommending, with clonal hematopoiesis, you start taking any sort of aspirin or things like that for the cardiovascular benefits. Because that did not, in this study at least, did not show to have any preventative effects. And this is the team. Yeah, especially like to thank Katarina Mysin here, who did a lot of the analysis of the sequencing. And sorry, my slides are going crazy. I already thanked the Firefighter Cancer Initiative and the cores here at Sylvester who helped with all the sequencing process. And so would love to have your questions.
Okay, that was awesome, Dr. Taylor. Thank you so much. So for all of our participants that are signed on to the seminar, please use the Q&A function at the bottom to ask any questions of Dr. Taylor. While we're populating those, and Dr. Saleh and I will prompt you with them, I just wanted to say thank you. Like, this presentation was awesome. Like the way you walk us through broadly at the beginning with population level, what is clonal hematopoiesis, how it impacts the general population, those risk factors, and then pull us towards how firefighters are impacted, with CH, especially those that were involved in the World Trade Center, the World Health Trade Center response at 9/11. And then sharing with us the preliminary data from the work that you're doing through the FCI on this topic. It reminds me to always say thank you to our firefighters for being engaged with this research. We couldn't be able to do it without your participation in our cohort studies. So I know we do have a couple of questions and we have just a few minutes, so we'll try to be nimble and diligent in how we pose this to you. So I'll start off with the first one and then ask Dr. Saleh to jump in as well. Okay, so the first one is there a potential to study firefighters who have a cardiovascular event where a blood sample could be sequenced to evaluate whether those firefighters have excess clonal hematopoiesis mutation, which could be contributory to factors to their event? Could this data be potentially useful to prevent a firefighter from recovering and subsequently having a CV event? So I guess there's a sort of a mixed question here about CV events and CH, if you maybe want to clarify a little bit the difference and what they...
Yeah, no, actually, probably more than half of the studies that are coming out on CH are from the cardiologists from the cardiovascular community. They're very, I don't want to say excited about this, but they do see that it's a big part of the risk for cardiovascular events. So they want to study it. And as a hematologist, we study the blood, but they study the heart, which is they're connected. So definitely, I think, I would love to talk more about that, and especially working with, the cardiologists here to say exactly what they asked in the question is, studying it from the, not from the leukemia perspective, but from the cardiovascular perspective.
Yeah, absolutely. There's a question here about wildland firefighters that I'll leave a little bit towards the end, because we can provide a comment on there, but there's one here that's definitely in your alley. So with duplex sequencing, age-related increases in mutations were more apparent for exon mutations, while the splice site mutations were relatively constant across age. Is there an explanation for this difference or observation?
Yeah, the exons are the parts of the gene, because your genes have exons and introns. The introns are taken out when they make the RNA. So the exons are the parts of the genes that ultimately become the protein. we included these splice sites, which are actually part of the introns, because if you have a mutation there, it could possibly change the splicing, and then therefore you would maybe skip a whole exon. Again, this is getting very technical, but it sounds like they wanted a technical answer. So I would say the short answer is the exons are the most important part of the gene, and so that's probably why we see those enriched with aging. The splice site, we're not sure their significance. We wanted to include them in case, because they can be significant. We excluded a lot of the intronic mutations because, again, those would be not taken to the RNA level and then therefore not in the full protein. It's not to say they couldn't be significant, but we didn't include them. Again, we're trying to be conservative on just including the most likely to be functional mutations.
That makes sense. What is the cost of testing for CH today?
Yeah, so this sequencing that we did, which again is very sensitive, so I'm glad we did it, but it's on the higher side. So in this case, it was around 700 to 800 per sample. You don't have to do that level of sequencing, and it is getting cheaper every day. The cheapest that I've seen it for CH, one group from Vanderbilt is doing it for, I believe, $50 per sample. But generally, you would probably be spending at least 100 to 200.
Yeah, per sample. Okay, thank you.
Again, this is kind of the highest end of the.
Yeah, and it gives opportunities for other things too, right? With that data. Could clonal hematopoiesis have a prognostic value for risk stratifying a population of firefighters to identify individual firefighters with an increased risk of an eventual cancer diagnosis?
Yeah, that's hopefully what we can do here. Again, we detected this CH in all the samples, but I don't think that means all the samples have the equivalent risk. And I mentioned there is now this risk score, the type of mutation you have, the number of mutations, and the allele frequency that mutation is at. Remember, most of these are below our clinical cutoff of 2%. We detected them because we use this super sensitive technique. So I didn't show you the percentage that they were at. Some of them were at like 0.01%, but some of them were closer to that 1% or 2% cutoff. So those would probably be the higher risk. And again, that's work we hope to do, is to kind of then classify those and kind of pick out those that are at the highest risk, that again, we're following people, they may be at the highest risk of leukemia and possibly, again, right now we don't have ways to prevent leukemia from clonal hematopoiesis, but there's all these studies going on. So one day we might, and then they could be potentially notified once, if there is anything to be done.
Last question, because I know we're just out of time, and so I apologize to our attendees that asked a question and we didn't get to it. So there are some groups in California that are doing glutathione breathing treatments and infusions on firefighters to treat post-wildland urban interface fire exposures. There aren't any great publications on this treatment, but the glutathione supposedly acts similarly to vitamin C as a free radical mitigation agent. Do you think this sort of free radical mitigation could be potentially useful in reducing firefighter cancer risk?
Yeah, with the vitamin C, kind of how that is being linked to clonal hematopoiesis prevention is through specific actions on a gene called TET2, which I mentioned is one of the most common mutations, because vitamin C is a cofactor for that. It can actually increase the activity of TET2. TET2, the mutation, decreases the activity. Again, most of these mutations that we're seeing are decreasing the activity of the protein. So then in the TET2 cases, if you could increase that activity of the protein, you could potentially reverse the effects. Again, that's being studied in people right now. It would be great to study glutathione. A lot of these tests that are done in the lab, it's good, and it gives you the idea to potentially take it to a trial, but to actually prove something, a randomized trial where you take some individuals and you give them the treatment, and other people you give them a placebo, or they think they're getting the treatment because just the placebo effect can have a big effect on some of these things. So I would say, should be studied, but it's not being studied currently to my knowledge.
Yeah, TBD. Keep following to see how it helps. So I want to thank you again, Dr. Taylor, for your time this afternoon to teach us, what's going on with those research projects. To everybody that is joining us online, a recording of the presentation will be available on the FCI website, and you can always reach out to Dr. Taylor as well for questions. We want to thank you again for joining us for our monthly scientific seminar series through the Firefighter Cancer Initiative, and be well. Thank you all.
Bye, everyone. See you next month.
Bye.